you. Hello there. Welcome back to Bumps in the Road tent. I'm very delighted to introduce our next group of speakers. They're all colleagues from the Princess Alexandra Hospital in Harlow, and it's my pleasure to introduce Sam Taylor. If you could introduce yourself, Sam, and just
Sure.
remind everybody the session is being recorded again. Thank you.
So hi everyone, my name is Sam Taylor and I am the education lead and one of the senior clinical nurse specialists in the palliative care team here at the Princess Alexandra Hospital in Harlow in Essex. So I'm just going to share my screen so you can see my poster. I'm going to talk to you today about end-of-life care education and specifically the quality improvement projects we've been doing in relation to that. So our project aim was to identify in a timely manner our patients who are approaching the end of their life and making sure that we make sure that they die in the appropriate place and we treat them compassionately and we avoid any unnecessary delays if possible. And actually an indirect benefit of doing this as well was that hopefully it improved our mortality rates because we were increasingly accurately recording our expected deaths. So we started this in January this year and it ends next month. And our measures were that we wanted to improve our compliance with recording preferred place of care on Nerve Centre. And Nerve Centre is a trust-wide documentation and platform that we use for all our patients in the hospital. It's electronic, so really accessible and a really good way of identifying that. We also want to measure the time from assessing our patients for fast track discharges at end of life to the time it took to actually transfer them to their preferred place of care. Now we know there was lots of factors that delay people from leaving hospital at end of life, but we really wanted to look at those and understand what the barriers were. We wanted to measure our increase of patients who are discharged with a peace document. And a peace document is an advanced care plan for future care that we use both within the trust and in our local community. And we also wanted to measure the amount of staff that attend Sage and Time communication skills training. Sage and Time is a validated evidence-based communication skills course that lasts for 3 hours and it's like basic level foundation skills. And we also wanted to measure the number of YouTube video views, on our videos that we make, and I'll talk about them in a bit more detail later on. So our project team was myself, like I said, I'm the education lead for palliative and end-of-life care within the trust, but also Jill Hutchinson, who's the clinical lead and the lead nurse for the specialist palliative and end-of-life care team, and of course Quality First as well. So our test for change. So we started auditing our individual care plans for anticipated last days of life, which is a document that we use within the trust for when patients are identified as approaching the last days of life. We use that paperwork and we started documenting that on a monthly basis. We've also developed a staff survey, so we've sent that out to all members of staff who are clinical to understand their learning needs and their wants, because we thought that actually people who are doing this day in, day out are probably very acutely aware of what further teaching and training that they want. So we asked them. We also looked at training for the Sage and Time course. So like I said, because it's validated, it's a very specific way that the trainer learns, and so we managed to we've started sending people for that train the trainer course. And we also updated our training that we deliver on our wards and in the departments, and we did do a few kind of regular sessions, but we've really looked at that and really ramped that up over the year. So our results are, so we've developed a wide range of YouTube videos on a wide range of subjects such as advanced care planning, our documentation, symptom management, those types of things. And we've uploaded them to our Trust YouTube portal, which means that they're available for staff at a time that's convenient for them. And it just acts as a resource for everyone. And those links are shared widely, including on our own internal intranet as well. And I've spent the last 9 months or so developing a mandatory e-learning module, which will, once it's finished being built, will be rolled out to all clinical patient-facing staff. And that will be on a 3-yearly basis, so that will become part of their mandatory training within the trust, which we've had to get executive level support for that, and as you can imagine is really fantastic, because it means that we know that all of our staff will have a baseline foundation training when it comes to end of life care, and it also means that the trust understands that this is really, really important, and this is something that involves all of our staff, not just the specialist teams. And again, an e-learning module is a really, really effective way of making sure people actually access that training and do it. So we're really, really proud of that. We've also worked really closely with our hospice colleagues. So where we sit geographically, we sit between the borders of Hertfordshire, West Essex, and also North London. So we often have patients who come from all of those different localities, and therefore we are actually talking to a lot of different hospices. And because hospices are generally independent, they all have different admittance criteria. So actually for us in where we sit, it's really important that we understand each of our hospices and what they want from us when we're referring to them. So we've done lots of collaborative working with them to make sure that we understand what they want from us and their admission criteria. We've also implemented the electronic recording of preferred place of care and preferred place of death on our nerve centres. So that means that we physically had to build in an extra column. We've had to also, you know, teach and train our staff that this is now available. We've worked very closely with our transfer care team, who are like our discharge team within the trust. So that's been really, really good. And we have audited that as well and seen that people are using that, which hopefully will prompt people to have these conversations with our patients and ensure that we are actually asking our patients where they want to be towards the end of their life. And then we've also, within the specialist palliative care team, the clinical nurse specialists, we've now linked to individual wards. So they're spending more time getting to know their individual wards, getting to know the staff, spending more time on those particular wards. So we're not missing those in the moment teaching opportunities. So we know that every time we interact with anyone, there is always potential for learning to happen. And actually, it's really important that as senior nurses with lots and lots of experience and knowledge regarding palliative and end-of-life care, that we're there in the moment, teaching the staff how to care for these patients and making sure that we're known as a resource too, because obviously, you know, we want to capitalise on any opportunity we have to improve end-of-life care within the trust. So we've been working much more closely with our link wards as well. So going forward, our learning and our next steps. So I think one of the big things we've learned is that actually having a variety of learning resources is really important to our staff. So that means face-to-face teaching when we can and when COVID allows. It means kind of formal teaching, maybe over Teams, but, you know, like from a PowerPoint presentation or whatever. But it's also those in the moment teaching. It's having those videos available for people. It's having written resources. So staff can access them when it's convenient to them. So variety is very, very important. We also learnt that actually having an increased presence and availability of our specialist palliative care team was very, very powerful, and building relationships and building rapport with staff who are obviously delivering the care is very, very important too. So that's been a really nice outcome for us in the palliative care team. And also lastly, just the importance of collaborative working. So we would not have been able to do any of this if it wasn't for our colleagues in the community, from our local hospices, from the CCGs, but also our colleagues within the hospital who, like I said, are delivering this care day in, day out, and the importance of it being for everyone. So at any given time, about a third of all inpatients are in the last year of their life. So this is not just for this is not just a problem for the specialist palliative care team, but this is really, really important that everyone within the trust is on board. So I will leave it there, and obviously any questions.
How many staff do you have within your team, Sam?
So within the specialist palliative care team, we have it's about 5 full-time equivalent clinical nurse specialists, and then myself. So I mostly do education, but I am clinical about 2 days a week, so quite part-time from a clinical point of view. And then we do have a full-time consultant as well. And we're very lucky because we also have support from our local hospice, and their consultants come over for sessions about 3 times a week. So that's a really nice link actually with our local community. And as I was saying, that collaboration is so important, especially when we're talking about moving patients from the acute inpatient sector, maybe to the local hospices, maybe to their homes or local care homes and things. So having that continuity and having that relationship is really vital.
Yeah, sorry Sam, I put it into the chat, but I thought it was really great how you've connected CNSs to specific wards, because I think that knowing who to call and knowing who you can speak to and actually building that rapport with somebody for that learning and accessibility. So actually when you see a patient that you think, sometimes it's advocating for that patient, but being able to come to you and sometimes go kind of around the consultants or whoever's managing that care, but to be able to come to you, I think is really, really important in ensuring that that level of care is provided. So I think that's great.
Thank you, and I completely agree, Claire. And interestingly, actually, one of the kind of outcomes of us being more visible and more available is that we're not necessarily getting more referrals, but we are getting more junior staff phoning us to ask for advice and saying, is this okay? Is this right? I'm worried about this. And actually breaking down that barrier is so important, and them feeling like they can contact us and we're not this far away team that only comes to see patients, but actually, like you're saying, we're here as an advocate, as support and for advice is really, really important too. And going back to the link nurse kind of scheme for us, actually is that each ward area do have different needs, and it's very easy for us to just think that everyone needs the same thing and we just need to provide more training, but that's not actually necessarily the case, because some wards that have, you know, that have a higher percentage of deaths because of their patient group, we might think they're very, very good, but actually they might struggle with that and need someone to debrief and talk to, which obviously is our role as well. So it's really getting to know that individual ward area and seeing what's important to them and what we can help them with. And yeah, I think we've surprised ourselves actually in how valuable that's been going forward.
Excellent, that's been really great. Thank you, Sam. Are there any other questions for Sam before we invite our next speaker to?
So if I could just dive in, just to say I'm horrendously biased because I work at the Princess Alexandra Hospital as well, but just to say well done and thank you, Sam. The work that you and your team do is phenomenal. So thank you very much.
Thank you, really appreciate that, and thank you so much for letting me come and present today. It's been fantastic.
Thank you so much, Sam. And Robbie's just highlighted in the chat as well that Sam and her colleagues have posted some of their end-of-life education and work on the Fab NHS Stuff website, so it's available there. And I'm sure Sam is up for being contacted. If anybody has some questions, that would be super. Thank you.
Of course, please do. Thank you very much, everyone.
Thank you very much indeed. Okay.
Hello there, so my name is Lisa Thurley. I am the virtual visiting coordinator at Princess Alexandra Hospital. I came into this role in July, at the end of July of this year, but a lot has happened with the virtual visiting service before I joined, but I have been part of the trust for 14 years. So it was very exciting for me to come into the team and see what I could do to help embed and take the service further. But it's an absolutely amazing service to be a part of. So I'm going to share my screen. I'm going to start with the PowerPoint and do my best. So I've gone. Okay, so I want to start with, where did it start? So virtual visiting started alongside Message to a Loved One. It was April 2020, so in the midst of the COVID-19 pandemic. Overnight, it developed into a critically needed service for our patients. Teams came together to set up the service. that included IT, Quality First, Associate Physicians, the Anne Robson Trust, Patient Experience and Voluntary Services. So on April the 16th, virtual visiting and message to a loved one went live. So there was a very quick turnaround for these teams coming together, collaborating to really ensure a safe, secure and efficient service could go live in a very, very short amount of time. Service aims. We wanted to improve the care and experience of our patients using secure technology to link patients with their families. How did it work? There was no need to download an app or sign up for anything. Phone calls are sent to a cloud-based telephony system called Attend Anywhere, and emails are sent via hospital staff's NHS email addresses. Clicking on the provided link at the agreed time, the two parties are brought together virtually. The relative or loved one would go into a virtual waiting room whilst they waited to be connected at the patient's bedside. So virtual visiting, message to a loved one team can deliver care and connectivity across the front line, presented efficiently within a cyber secure environment. So very excitingly, the service was nominated and became a finalist in the HETT Award, which is the Healthcare Excellence Through Technology, and a fantastic achievement. It won first place, and it was an absolute credit to the teams that had come together to build this service. The collaboration shone through. Here you can see on the left some individuals that made up the team, and on the right there those at the awards, receiving the award, big smiley faces, of course. So as a team, we believe having a digital culture is integral to the development of healthcare, building on the core value of having the patient at heart. Bruno, seen on the left at the back to the left in the light trousers, and on the right, right at the back there with the light shirt on. He's been part of the team from the start and continues to be a vital part of the team. His dedication means that we can run a 7-day service and ensure our clinical practices are safe and up to date. We still have a lot of support across the teams that came together for the service. So if we were to look at virtual visit in numbers, April the 16th, 2020 to December 31st, 2020, there were 1,063 visits. January the 1st, 2021 to November the 23rd, 2021, 872 visits. In total, making it 1,935 visits since the service started. But whilst we do look at numbers, we must remember that these numbers represent every individual, a patient in our care that has experienced a visit connecting with a loved one. It's definitely quality over quantity. What I'm finding now is that we can give the service a little bit more time. We're able to, because at the beginning when we started the service, they were very much booked in 15 minutes at a time, you know, with visiting being restricted. This option was very popular so that they could connect with loved ones. And we can definitely see it was a service that is being used. So whether or not we deliver 1 visit a day or 5 or 6, every single visit has an impact. I did visit a gentleman on a ward, and he was speaking to his son via his mobile, but didn't have a video camera on his phone. So we went along and did a virtual visit, and the feedback that you get when you're with the patient on that call is amazing. He got quite emotional and said, "Thank you for this." to his son, he said, "Thank you, mate. It is so lovely to see you." And that is so important. Really important to know that we are making a difference, giving this option to individuals. And is there anything else I wanted to say on that? No, but going on to where can we reach? It's very exciting. The virtual visiting has opened up options to those that are living across fields and oceans. Not only are we able to get visits across the UK, but we have had 85 international calls across 22 countries. Some of them seen here: Spain, Sri Lanka, Japan, Greece, Australia, Bangladesh, Brazil, America. And very recently, actually today, the patient should be leaving the hospital, but we have had some feedback from the relatives in America. So a comment from the relative is, "The issue of connecting with my mother is exacerbated by the fact that I also live permanently in the USA, 6 time zones away from the UK. I have been so very grateful for the opportunity to speak with my mother via video link and to send her emails via the Message to a Loved One service. Seeing her on screen has been a lifesaver for us during the pandemic, and never more so than this stay in the hospital. She loves the emails and associated photographs that come in from my American family, including her grandchildren, and enjoys looking at them over and over. She calls them her telegrams, and they bring her comfort during what has been a very difficult time." And in another comment there, you can see that that it's perhaps one of the few blessings of the pandemic, but a blessing nonetheless. And a comment from the patient that this is an immense morale booster. Thank you. It is such a vital service. And oh, I better be quick. It's 10 minutes already. We had a case study here for hearing aid batteries. We believe that the service is very much a holistic approach to care. In medicine, holistic is characterized by the treatment of the whole person, taking into account mental and social factors rather than just the symptoms of an illness. Very quickly, in this situation, the daughter was in Turkey. She wasn't coming back to England for 3 weeks, and then was seeing her father a further week later. There was no one else that could help outside of the hospital because his wife was at home with undiagnosed dementia, and we wanted to help. So we rang the audiology department at St Margaret's Hospital, arranged a visit the very next day for them to come along and assess the hearing aids and deliver some batteries at the same time. And I would definitely say that this service, virtual visiting service, embodies all of our values: patient at heart, everyday excellence, and creative collaboration. You can see there some comments from the relatives that have had visits. There, I just want to highlight, thank you very much for all of your efforts to keep patients and family connected, which is very helpful to their mental health and to the mental health of the family members. Everyday excellence, a few more comments there. I sincerely thank you for all the good work you are doing, and especially for helping Mum and ourselves, because she needs to know we are here for her. We cannot contact her any other way. And the collaboration really has been an essential part of this service being successful, from IT, quality first, end of life, speech and language therapists. Thank you for those referrals coming from the wards, doctors, nurses, ward clerks. There, a comment from a ward clerk: "Your service is amazing, so amazing. It has been fantastic in these difficult times." And we've had dementia care collaboration and the communication teams and many, many more individuals. So yeah, so a really big thank you. This service would not have been possible with staff volunteers and volunteers that have come in to help run the service. The next steps is to increase the awareness, to make it a business as usual option for visiting at the hospital, and to expand our holistic approach to patient care.
Are there any questions for Lisa about the service, which is an absolute lifeline for patients and so important at this difficult time? Are there any questions? So you were saying about you're hoping to continue this service, Lisa.
Yes,
you're hoping to get more people, more resources, or how are you hoping to take it forward? Because we're still in the pandemic at the moment, so we still have those restrictions in place.
I mean, we're hoping, because the Trust Board really do hope to continue the service. We can see that it's been successful, and we've had people use the service, and we don't want to take away that option. So I'm actually going through the process at the moment of recruiting volunteers who would be able to help take the service onto the wards and actually see if we can make it different times, because at the minute we run the visits in the afternoon, but obviously with our international calls we do need to offer flexibility, and we do need to get the communities locally and further afield aware of the service. We have had feedback from relatives and loved ones saying, if only I'd known about the service sooner, when their loved one had been in for a couple of days or even a week. So the ward clerks have been so vital for the awareness of the service. So it is just now about embedding it in. It's such a young service. We have got room to grow and develop. So yes, just getting those resources and communications. I mean, communications have already been fantastic. We just need to go that little bit further.
Absolutely, and they need to be continuous. We do have a question out there. My colleague Maria from the Royal Wolverhampton, she had a question, she had a hand up.
Apology, Vanda. I clicked the wrong button, but it's just a fantastic session anyway. It's great to hear about it, and just a comment from me, really, just how fantastic this has been. Certainly working from a clinical perspective, seeing the communication that the patients have had, just brilliant, and long may it continue to rain. I've not long got off a call actually from a patient just saying that he wasn't able to communicate with his family whilst he was in A&E for some considerable time, and somebody came along, one of the doctors, with just the most simple application, and away he went, made a huge difference. So yeah, long may it rain.
Oh, thank you. That's really lovely to hear.
And congratulations about your award as well. So
yes,
yeah,
absolutely amazing. The collaboration, honestly, it was absolutely critical and vital. So that award was so very much deserved.
Deserve your recognition anyway. Thank you so much, Lisa. That was really insightful. Thank you.
Yeah, I can see it.
Okay, so my name's Nicola Tikasingh. I'm the lead nurse for mortality and quality at the Trust, and I started this job nearly 2 years ago. And so my role is to look at pulling out learning from death. So I'm just going to give you a little brief about what we've been doing at the Trust. So the background to this is that the CQC did lots of investigations up and down the country in 2015 and 16, and they recognised that NHS acute trusts were not learning from their deaths, and so repeated incidences and errors were happening. So they worked very closely with the Royal College of Physicians to pull together some national guidance on learning from deaths that they asked all acute NHS trusts to implement. And part of that included the National Mortality Case Review Programme, and they are called structured judgment reviews. So they're mortality reviews, it's a scrutiny of that patient's last admission, but it's not just looking at bad things, it's looking at when things go well as well. So it's celebrating what we've done well as pulling out things that potentially we could have improved on, and then looking at how we can make adaptations to improve the quality of that next patient's care. So historically at the Trust, we have been an HSMR outlier, and our HSMR data has been significantly high since November 2016. So HSMR data is given to us by a company called Dr. Foster, who basically they are telling us that it looks as though from a data perspective that there are more patients dying, coming into hospital and dying who shouldn't be. And we have also been an outlying mortality group for pneumonia, aspiration pneumonia, acute kidney injury and sepsis for 2 years. So that means those groups, those mortality groups, they're saying there are too many patients who are being admitted with that condition who then go on to die. So Dr. Foster don't look at specific information about the patients. This is all pulled from data. So what we decided to do was apply a governance process around learning from deaths. So the trust put into place medical examiners. Medical examiners are consultants who are all independent to the patient's care and treatment, and they will do a review of that patient's last admission. And these are for all in-hospital deaths. And they will pull out cases that need to be put forward for an SJR. So they will be things like the patient was involved in an incident, involved with a complaint, perhaps they died after surgery, they were readmitted within 30 days. So they are specific things that they put forward that's all in line with the national programme. And those cases are put forward for reviews, and any learning gets taken back to our specialty teams so that they can learn from that. We also put in place a robust learning from deaths process. So we've got a policy now in place that shows that PAH is actually learning from our deaths, and this is the process that we are following. And we also review avoidable deaths. So if we do feel that a death is potentially avoidable, it goes through a formal governance process where it's discussed, and it also goes to a panel of people, which includes our governance lead and also our chief medical officer, and we decide collectively whether we feel that patient's death is avoidable or not. If we do think that that death is avoidable, then we go, obviously that gets reported through that formal governance process. We discuss it at another incident management meeting, and we have to report that to the CCG as well. And that gets followed down as a different process. But we feel quite confident now that we are reviewing the deaths that absolutely need to be reviewed. We've also made sure that we've had a relaunch of our M&M meetings across all specialties. So when I started this job a couple of years ago, there weren't that many areas that were doing M&M meetings. Now we have more, a lot more, not all, but we have a lot more specialties that are undertaking M&M meetings. And also we've tried to make it a more multidisciplinary approach where we are involving not just the doctors, but we are also looking at involving the therapists, the junior doctors and the nursing staff as well, because we should all be learning from our deaths. We've also been doing audits and deep dives into those outlier groups that I explained to you to try and understand why we are an outlier. And I have to say the majority of the time we have not picked up that there's poor care and practice. The majority of the time it is in relation to poor documentation, inaccurate documentation and inaccurate coding. So we've done a lot of work around trying to improve that, and we are continuing to undertake audits to keep on top of that. We've also implemented a system called SMART, which is a website where we collate all of our information on learning from deaths. So the medical examiners do, when they do their reviews, they now do it on this system. And all of our structured judgment reviews are done on the system. The system is really clever and it helps to pull data and themes for us to help us look at what our themes are and where we need to put work. And then we have been networking with other organisations to look at how they have implemented this national guidance as well, and if there are any things that we can learn from them, which has been extremely helpful during COVID, because it's helped us to see how well actually we've managed COVID compared to other organisations, and also how well we have managed to review our COVID deaths compared to other organisations. So the ongoing work we have, we're continuing to collect SJR themes so that we can continue to look at where our errors are, but also where our good pockets of care are, so that we can celebrate that. And in doing so, we're reviewing the care and treatment to look at whether we do need to change that. We've been doing a huge amount of COVID learning and looking at our nosocomial cases as well. So that's been taken up a huge part of my time over the last 18-20 months now. We are continuing to work very closely with coding and the mortality outliers, and so we undertake audits on a weekly basis to look at whether things have been inaccurately coded or in fact is right, because to make sure that our HSMR data is accurate. And then we have mortality improvement programs. So these have come out from some of them from our SJR themes, but also work that we realised we need to improve on. So we have programs with the Quality First team who lead on these with the relevant clinicians and teams. And we look at fractured neck of femur, end of life, aspiration pneumonia, and sepsis. And aspiration pneumonia was a really big one for me because that was an ongoing theme that was pulled out from the SJRs last year, that we had so many patients coming in with aspiration pneumonia and being nil by mouth and not being seen by a speech and language therapist until sometimes 4 or 5 days, and so they'd had nothing to eat or drink, or patients developing aspiration pneumonia whilst they were in hospital. So there's a big improvement program going on there to look at what we can do to improve that. So our HSMR has now moved into the expected, oh, that frightened the hell out of me. Our HSMR has now moved into the expected rate. So we are now no longer an outlier, which is brilliant, but we still need to understand a little bit more as to how we've managed to come out of it, because at the moment we just feel like we've been firefighting for a couple of years and we're not 100% sure how we've managed to improve that. So that's something that Faye, the Chief Medical Officer, and I doing some work with Dr. Foster to try and understand that better. And we do have future plans. We want to share learning from deaths across the whole organisation, and the only way that we can do that is via our M&M meetings to take place across all specialties. We're going to continue to review our outlier alerts, even though we are no longer an outlier for sepsis or acute kidney injury. We're still continuing to audit those case notes just to keep on top and make sure that our data is accurate. We continue with our mortality improvement programs that are still ongoing, and there may be possibilities to start new improvement programs with any new themes that may come up, any changes that we feel need to be made to improve the care for patients. And we need to raise the profile for learning from deaths as well, and look at how we are taking that learning to all the correct forums, and that the people that are working on the shop floor are the ones that actually are learning from our deaths and understanding what we've done well and what we haven't done so well. And in turn, that will embed a really sound governance process for our learning from deaths at the Princess Alexandra Hospital. And that's just a summary of what I've talked about. Are there any questions at all?
That was really informative. Thanks, Nicola. Has anybody got any questions?
Just to say it's really important work that you're doing, and I bet it's important work that people often don't realise that's happening behind the scenes and that you're doing. So yeah, just to say, yeah, well done, and it was great to listen to.
Thank you.
Yeah, carry on talking about it. We talked about it in the previous session, action learning set, but yeah, you must raise your profile and keep chipping away, and really if people understand what you're trying to achieve, maybe you know, they're engaged a little bit more. So you've got lots of ideas, you've spoke about them this morning. So I think the coding mechanisms as well have changed, haven't they? Because I think some of the recollection about mortality, were we coding appropriately? And so the powers that be were trying to get parity about how our colleagues were coding episodes of care and episodes of death. So I think that's been an important part of really getting to grips with the M&M about appropriate coding and the messages there.
That's been a huge thing that we've pulled out, and I undertake audits on a monthly basis with our head of coding for our outlying groups, and it's amazing the learning she takes from a coding perspective and then the learning I take from a clinical perspective, and obviously she takes individual learning back to those specific coders who have coded them, so that's hopefully teaching them for next time round, you know, they're understanding things better. But it's a really powerful piece of work to do.
I actually did some shadowing of coding colleagues because I didn't quite understand what they did, and I wanted to include coding within my research. So it was really enlightening, and the job is so complex. So I definitely encourage everybody to have a greater understanding what our coding colleagues do. It's really a very skilled job.
Yes, it is, definitely. And I think, unfortunately, I think it's just unfortunate that I started this job just before COVID, and everyone, especially our medical doctors who have the most number of deaths and the most number of SJRs, have just been completely swamped. And I know everybody's been saying it, and I really don't think it's an excuse. It's they have been so overloaded with work.
Absolutely.
I see Robbie's got a question.
I think Robbie's got a question.
Hi, Nicola. Well done. Amazing work. Yes, again, I'm biased, coming from Princess Alexandra Hospital, but do you ever see a day when we'll be able to share learning from death across hospitals, etc.? Imagine if we had SMART across the NHS or something similar, so that we could aggregate up that learning. I think, you know, do you see that happening, and what benefits might come from that?
I think that would be fantastic. So I was linking in with a colleague at Southend Hospital, and she told me that when she started this job, she started about 4 years ago. She told me that there was a network that was going on, a central network where they were all meeting, but that sort of didn't last very long. So we're looking at who we can contact to get that started up again, because I think that would be a really valuable piece of work.
Thank you so much, and thank you to all our speakers on this particular session. We're going to close now, so if we could start.